presentation to try, like, I'll say like 3 things. Like the first one is to give you a little bit an update on like wastewater testing. And the second one is to show you a little bit an update on what our results here at University of Idaho. And the third is to talk about this pilot grant for the IMCI that we're putting together. So I'm gonna present a little bit our aims, and I like to get that around like a discussion with everyone. So if everyone has ideas or like want to stop during the talk, like don't hesitate, like during the whole talk. And so for that, I use this kind of like classroom response system that I never used. So it's kind of an experience that is called Per Deck. It's like a Google like a classroom response system. So you can go to joinpd.com, put the letters as a code. You can skip the little like emoji if you, how do you feel? And you got already a first question to answer, which is, tell me something you already know about wastewater and COVID. And so I'll like see and start that. So it's a, I would like to get that.
Is there a space between the V and the J?
No, you don't need. Okay, and so don't hesitate to like to talk during the like the presentation, so we can go more around a discussion than a presentation. Oops. Okay, so I'll try to see how I can deal with that. Okay. Ooh, I can see. Can you see the response? Okay. So what people say, people poop out various particles, which can measure in wastewater. Yeah, pretty much. Thibault is the best at detecting COVID in wastewater. I'm not sure. I think there's like much people that are much more advanced for that. But thank you. Virus residuals in wastewater, useful resource for surveillance across population. Okay, it seems like a good way to monitor relative change in disease prevalence in an area, but perhaps not accurate quantification of active disease. That's a good question. Yeah, that's I'll address that actually like when in the middle of the talk a little bit. And if I don't, try to remind me. You can detect outbreak before they go out of hand. Yeah, that's happening locally. Has detected outbreak successfully. Okay, so it looks like most of the people already know most of like what we can do with the wastewater, right? Can we, oh, there's a question. Can we detect mutation in the virus? The answer is, I think, yes. And I haven't read the papers about that yet, but I saw there is a couple groups that started to do that. And with nanopore, I think there is like people trying to see from the wastewater if you can see, like get like full viral genomes and look at their the mutations and the virus. Okay, so let's go. So it looks like most of you already know a little bit like why wastewater can be used to predict like COVID-19 outbreaks. So that's gonna make the work easy for me. But before, since the discussion, and I don't know how far we're gonna go, or before I forgot, I put the thanks, like a little bit the group that is involved like in that project at the first slide, and the founders too. So here is like our team that is composed of those 6 amazing people. So we have mostly like Cindy and Erin that are doing all the hard work in the lab of like getting the samples and extracting the RNA, do all the quantification. And then that's happened in 2 labs. So like in Eric Cott's lab, so it's a collaboration between the engineering department also and the biology department with the top lab. And we've been working closely with Ben Reed in our labs, and especially recently with Tyler, with a postdoc in Ben's lab. And that's helped me to put together this proposal where we're going to try to do some modeling. So he's going to be our modeling guy. And in terms of funding, our fundings are from university. So the Moscow now, very recently or soon, the IMCI, and some discretionary funds from Top, Reed and ours, and Coates Lab. So I would like, let's look a little bit first, like, so it seems like we getting right now into our, so people call it second wave, but it looks like a little bit of third wave. So those are kind of like the total confirmed COVID-19 case per day normalized by population. And you can see here highlighted the United States, Idaho in green, and I put France because I was curious. So you can see a little bit what happened in Europe, where I'm from. So you can see that France is doing very bad. So what you can see that for now, Idaho looks like we are much more like in terms of like cases normalized per population, way above like the rest of the United States, which is kind of a worrisome. What is very interesting though is to see the daily COVID-19 test positivity rate. So that is very high actually in Idaho. And I got a little question for you, so we can all like think about that, where I'm like, why do you think, like, what is your thought about this high positivity rate in Idaho? So you can see like here, it's like this graph shows the positivity rate over time for all like different, from different states in the USA. And you can see that Idaho is one of the top one with like almost more than 40% positivity rate in the testing. So what do you think, why this number is so high? Okay.
That's a pretty easy question to answer, Thibault.
I know. There's no hard question. It's just like for have interactions with the group a little bit. Okay. I don't know if when I say show responses, if I can still like, people can still answer. Can you still answer when I like, we're looking at the answers already? I don't know if people still, yes, I see some ads. Okay, not organized response to the outbreak, no response at all. Okay, so that's more like the idea that there is no like control of the spread, low population density relative to higher rate of mass adverse behavior. So I see the high rate of mass adverse behavior. I'm not sure if I understand why the low population density make that positivity rate high. If there's any like one want to say why, I'm not sure if I understand that. Lack of testing, that's one of them. So basically, if there is not enough testing, the positivity rate is very high. Lack of mask on other compliance, social distancing not in effect, limited testing outside the University of Idaho, which is true. And I can still answer. Okay, thank you. So little testing, yeah. So that's basically like, it seems that according to like the world, like the WHO, like there's like if you above like the positive rate is above like the threshold that determined is like 5%, it means that you don't do enough testing, and so more testing is needed. But it also showed that the virus is spreading very quickly, like in a non-controlled way, which most people like here in the state, right? So if there's any other thought on that someone want to share? Okay, no. Social distance. Okay, so that's kind of like, it looks like our testing is a little bit too low in Idaho. Next question is gonna be, there's a lot of those at the beginning and there's much less after. It's like, I found it was easier to ask everyone question at the beginning than after, when I'm gonna go more like talking in our results. So what do you think, like what are the strategy we can do? Like, how can we get rid of that virus? Like, how can we stop it? Like, you can just put like one thought, like, or I have a slide after where I put my thoughts that I had. Masks are somewhat effective, so are social distancing rules. Okay. Show people, yeah, masks, social distance. Yeah, non-necessary gathering. Masks are somewhat. Oh, that's pretty cool. We can see the people in live, like writing. Catch case early, yeah, and isolate. So basically contact tracing, early detection, Mask is the one that is, and social distancing. I see that are what's most people but and like social distancing, like gathering, restriction of travel, vaccination. Yes, that will be great. Mask, restrict travel. Okay, so that's a little bit like I see all the answer a little bit of whatever like thought about it like yesterday night when I put that slide. So the first one would be best would be find a vaccine. Cures, find cures. I think there's people like at universities working on kind of like targets to find cures, right? I see the JT is here. Is that what you're trying to do, JT? I don't know if he's answering. Oh, maybe he's not.
What, Thibault?
Oh, is it like what's the research project you're working on? Is like on
animal transmission.
Oh, it's animal transmission. Oh, okay. Okay, I thought there was someone else like working on finding cures.
Jagdish is a little bit.
What do you say?
Jagdish is doing that a bit.
Oh, okay. So maintaining social distancing, avoid unnecessary travel. We all wear a mask. More testing, improve contact tracing, and rapid testings. And so that's a little bit like rapid testing where I think our projects comes in. So here, like, and how we can understand that. Oops, sorry, trying to like hide everyone now. Okay, so like, if we could get like a very quick like testing, that would be a way, one of the way that we could like avoid that the virus spread right through the community. The problem is that with clinical based symptom, the testing usually come a little bit too late. That once someone is detected to have the virus, there is already a chance that is like spread the virus to someone else, like transmit the virus to someone else. And the main reason is because there is like this pre-symptomatic phase where someone before like showing any symptoms already start to shed the virus. So here you got like this theoretical like it's based on literature, like a viral like shading of viral genomes over time since and so here you got like here is the time since symptom onset. And usually it takes like about 5 days for someone to show symptoms between the time he got infected, the person infected, and show the symptoms. And then here you got like the timeline with the mild, moderate illness, severe illness, and critical illness. And you got other like information on that graph with like the response with the antibody and the different type of like response, like hospitalization and so on. But what is very interesting to see is that it looks like from the literature that the thought is that the maximum load of the viral load like that someone is shedding is at the time of the symptom onset or during the first week of the illness. And even some people like some like a model basically estimated that it could be before the symptom onset. So like two days before the symptom onset. But that means that someone can like transmit the disease before even he knows that it is sick. And that's the main issue we're dealing with because apparently more than half of the transmission that happen are due to like asymptomatic or pre-symptomatic people. And so even if we do clinical based testing, we still have a little lag to prevent the spread of the virus. And that's where like wastewater-based testing comes interesting because it can detect the virus in the population before the symptom are start to like before the symptom onset. It can provide a good estimate of the prevalence in the population because by shading the virus through our stools, and I will come after on that, it can we can detect symptomatic but also asymptomatic people. It's very cost effective because like by just like targeting the wastewater at the wastewater treatment plants, which is a place where all the wastewater in a city comes, you can like have a global like overview of what's happening in that area. But there is much more you can do, and that's people starting to do, is use wastewater-based testing as early warning of an outbreak. So basically, like if you can detect the virus even before like in a community, people like you start to see a lot of cases reported by the healthcare department, you can already see that you're gonna go through an outbreak and maybe enforce some like restrictions. It can be used for tracking the impact of medical and social intervention, identify area of concern, so like specific neighborhood, for example, or on a campus, specific like houses or housing building, and can be deployed in area with limited testing. Can be used to predict, maybe that's something that we would like to do. So can we predict, like forecast like an outbreak only using like a viral like a concentration in wastewater, and also to track the evolution of the virus by sequencing. So why can we test it, like detect it in the wastewater? First is like the viral shed through like mostly like through like the respiratory droplets, but also like, and so that's where apparently most of the transmission between the people happen. But we shedding the virus also, like someone infected shed the virus through the stools. But what is not clear is whether or not if there is a transmission that can happen from like basically like a fecal oral transmission. That's still like unclear. So it seems that the virus can reproduce in the GI tract, but there's no like very like a data that shows that there was like fecal oral transmission yet. So viral shedding the stool. So there's like a lot of studies being like trying to like detect basically like in a nasal swab or like a throat or stools, like see how you can detect people that are infected. And it seems that overall the prevalence of the stool samples are about half. So half people are sick or infected, sorry, shed the virus through the stools. So that's not everyone. So that's already give you an idea that like the people, when they go to the bathroom, the people that are sick, there's only half of them that might shed the virus through the stool. So not everyone does that. And in terms of dynamic, it seems that the dynamics, so there's not much more studies since last time. Those are slides that are presented recently, and I think a lot of people here saw that talk. So it's a little bit like a redundant, but there's not much more new data, but it looks like the shedding through the stool is longer than in other samples, like, such as like swabs in the nose or like a sputum. And so here the gray lines represent like the detection of the virus in stools. And you can see that, well, after 2 weeks, like those are two examples of two individuals, but there's much more studies. And everyone's like, all those studies agree to say that in the stools, you detect the virus longer. And that once you detect the virus after symptom onset, overall it goes down. Like the concentration of the virus RNA, or like the number of copies, goes down overall. So that's something that is interesting to remember, because it's been suggested that by detecting the virus in the wastewater, you mostly detect new infection case rather than people that are like already sick. That was kind of like it's a big question about like whether or not when you detect the virus, it's like, do you detect people that got infected like last week and still shedding, like, or have the symptom and got detected positive and then continue shedding through the stools? Or do you detect new cases of infections? So based on the fact that the concentration seems to go down over time, and you can see this is a logarithmic scales, mostly new infection will result in like a input of virus in the wastewater. And so like if you have like, let's say someone like 5 people got infected, and you will detect the virus in the wastewater, and then you see a decrease of the viral concentration in the wastewater. And a week after you got 5 other people, then those 5 other people contribution will be much higher and may result into like, and see an increase of the concentration in the wastewater. So that's kind of like the rationale behind the idea that with wastewater, you're detecting an incidence of COVID-19. Well, there's recent studies like that looked a little bit more also what is the stability of the virus in wastewater and water, and that found that that's a study quite interesting. But what you can see is at first like on the left. So there's a study that looked at how many viruses are still active. And it seems that the time it takes to get 90% of the virus like inactivated in water at room temperature was like about 1.5 to 1.7 day. So it's pretty rapid. Like once the virus get into the water, it seems that it get inactivated rapidly. And on the right, the graph here shows the declining concentration of RNA. So that's not like the number like of active virus. Like so for the SARS-CoV-2 or the agent of the COVID-19 or the MHV, which is like a mouse model, like it's like a mouse coronavirus that is like closely related to the SARS-CoV-2. And you can see here, they tested like untreated wastewater, autoclave wastewater, and tap water. I'll move you all, otherwise I cannot see my slides. And so what is interesting to see is that the effect of the temperature is quite important, because at 4 degrees, like it takes like the time it takes to get 90% of the RNA like degraded, it's estimated to be like about like 60 days, almost 60 days. And then you can see that when you got like a higher temperature, that time is decreasing significantly. So that really showed that once the virus like is in the wastewater, it getting activated pretty rapidly, but you can still detect the RNA for a long time. And so there is like other studies that haven't been published, but there was mostly in a presentation and webinars where people like tested in the lab, like when you add like a virus to a wastewater and you put into the fridge, how long can you wait until like you see a decrease in concentration? And now it seems to be like 4 to 7 days, you don't observe like a significant decrease of the concentration. So you can like, that really show that probably what you detect at the wastewater, which probably takes less than a day to come from the bathroom of someone to the wastewater, it is reflecting like a somehow maybe that there's not much degradation that may happen during that time. Okay, I'm clear. Oops. So based on that, so that's kind of like a little bit like the background on that, and the fact that people been using like the wastewater to detect the virus. And what is very interesting is that the dynamic like of the viral concentration in wastewater is somehow foreshadowing the dynamic of the clinical case that are detected. And so here I put 2 early studies. There's much more now that shows that very well, where, and all the studies agree that it's a 5 days, there's like a 5 day to 7 days like lag between the wastewater testing and the detection of clinical cases. So on the left, you got in blue, the viral titer in the wastewater that is like in Massachusetts, and the number of cases after, and you can see like basically the trend is like is very similar, except that there's a little bit like your detection is earlier in the wastewater. That one is like a study from Yale University, where they also like, so in the red is like the viral RNA per ml, and in the black line is basically the COVID-19 new cases. So that's kind of pretty clear on those 2 studies that for those 2 studies that the wastewater can like predict like the concentration of the virus in the wastewater can predict the COVID-19 cases. That's quite interesting. And based on that, since then, there's been a lot of people that's starting to do like a wastewater detection. And that's kind of like a map that shows a little bit all the people, like I just put the USA, but because in the world there is like much more people, obviously, but all those little points, and including us here, are all the team that are working on wastewater detection of the SARS-CoV-2. And one thing that was not shown on that map is Boise is doing that. The wastewater of Boise is monitoring the virus in their wastewater, and they have these. I forgot the name. The board.
Dashboard.
Dashboard. Thank you, Erin. They have this dashboard where in live they put their results, of the concentration of the virus over time. And here on the bottom, they have the cases number. And so here again, you can see very well, it's a little bit more noisy as a data, but you can see somehow like the first wave, like you can see the first peak that was detected into the wastewater a little bit before, like they estimated 5 to 7 days before like they detected like in the county. Though you can see there's the new wave coming, but now like it's a little bit harder to see whether or not the detection in the wastewater seems to be almost equivalent to the detection of the clinical case. So that's going to be interesting to see what happened in the next days in those wastewater. Is anyone has any question or comment they want to add on that? Okay, no. Okay, so that's kind of like a little bit like the background, but I guess most of the people here like heard about it or was aware. And so now I'll show you what we do here at the university. So over the summer, we put that team together to all trying to set up like a protocol to detect and quantify the SARS-CoV-2 in the wastewater. And so what we do is like we collect the wastewater in Moscow at the wastewater treatment plants, where they regularly take like a 24-hour composite sample. So for those that are not familiar, a 24 composite sample is basically a sample that is representative of the average wastewater that came over the 24-hour into the plant. So like you have like a different way you can do it. You can either like set up a sampler to take like every 10 minutes a little sample of wastewater, and then you can combine this sample and you got an idea of all the wastewaters that arrive. If you want to be even more precise, you can need to account the flow rate, because the flow of wastewater arriving at the wastewater treatment plant is not constant. So then like there is auto sampler that take every so volume. So that's even more accurate. Or you can like reconstitute based on the flow rate, like your composite sample. So then we got that wastewater sample. The first thing we do is like we filter to remove big debris. And then we collect the filtrates. And we've been testing like this summer 2 different like techniques, but we're using the one on the left now, which is using like ultrafiltration. So the goal is to like concentrate for a larger volume into a smaller volume that we can use to extract RNA. So we could also like take directly the filtrates and a few microliter and extract the total RNA, but now the detection limit will not be good. So the goal here is to really trying to concentrate as much possible viral fraction in a small volume. So we concentrate by a factor of about 10 times, a little bit more than 10 times. And so we add the wastewater on the top like of this tube that has a filter, like an ultra filter that only the water or like every molecule that are below a certain like a kilodalton can pass through, and the virus cannot. So then we centrifuge and we like basically go from like 12 ml to like 200 microliter. And those 200 microliter fraction, we're using them to like extract the total RNA. And from there, the test is very similar to like what is done in clinics. Is we're using like the N1 primer that targets the N1 gene of the virus to detect the presence of the virus, and then using quantitative, like a real-time PCR and positive control, we're trying to quantify this virus into the sample. So one thing that has been shown is that each steps, right, we can lose some of our virus or the RNA can be degraded. So what we do is like we include an internal control in our samples using the mass coronavirus, so the MHV, this mass coronavirus that Tanya gave us, all our stocks, like, and so from there, not all our stocks, gave us some of our stocks. And so we can add up like a known amount to our wastewater and go through all the process. And because we know the amount of MHV we seeded, and then we can quantify how much we recover, we can have like a recovery rate, like of how much do we recover. And so we know we're losing like, our recovery rate are between 1 and 10%, which is pretty common in the literature. So we're losing quite like a certain amount. And some is because the virus like stick to particles. So there is like a part that's gonna stay on the debris. And then there is like other steps where we're losing some RNA or some other viral fraction. And also possibly like some things we've been working on lately, presence of inhibitors that are like in the wastewater and get co-extracted, like molecules that get co-extracted during the process, and that inhibit polymerase or like the reverse transcriptase also. And that can result like in lower quantification. Oops. So here are results for the Moscow wastewater. If there's any question on that process and what we're doing. No one has any question? Okay. So here's like our latest update from the city of Moscow. So on the left is a concentration per liter of wastewater. So the line, so what we do is like we do triplicates. So we got, for each date, we got a sample, and that sample, we do like an extraction of RNA in triplicate, and use the 3 RNA like for like qPCR, RT-qPCR to quantify like the viral fraction. So those are represented by the dots here. And then like the average, like the total average is represented by this black line. So what you can see first is that very recently, so basically last week, it looks like we went, or like, so those are just added the results like an hour or two ago. So those are our latest results from the wastewater from Monday. So that is collected on Tuesday. And those are results from last week. So it looked like we went through like somehow a peak or like an increase in concentration of the virus. And so I overlaid like with all the little dots here are the case number in the Lata County. And I somehow try to, so there's nothing very good, like use like a smooth line to trying to see a little bit the trend, but it's very difficult to see. And so it's very difficult to see here whether or not we're going up, but it looks like the latest, like, I don't know if there's any report for today, but it looks like there's an increase of like cases in the county right now. So that's gonna be interesting to compare that with our wastewater data. And on the right is something we need to keep in mind is that the number of the population every day that go to the bathroom might be different, or there might be like also some activity in a town that dilute the wastewater. So especially if you got a big industry that release like a wastewater, that can like at some time during the day, like it can really dilute like the wastewater. So then the concentration would look lower, for example. But one thing we have to keep in mind is we have to normalize the data. So the concentration of virus per an amount of people, like basically trying to normalize that. So there's different way to do that. So for now, what we've been doing is use what's called this BOD5. That is a pretty like a normal, like a, also like a normal measures that are done for wastewater quality to estimate the quality of a wastewater. So it's basically the biochemical oxygen demand for 5 days. And it shows the organic matter, we'll call that way, the amount of organic matter in your wastewater. And so that corresponds roughly to that amount of organic matter represents what's the amount of people that are contributing to your sewer. And so there is like pretty standard norms where actually that amount per country is very standard. So you can almost estimate like it's called equivalent inhabitants. So how many people like contributed to the wastewater you collected. So we've been using that for like normalizing. You can see that when we do that, the trend doesn't change so much when we do this normalization. And we're still working with other tools, like other marker to normalize, because the problem of that value of that normalizer is that you have to wait 5 days to get the results. And so we are now working with other chemicals like that can be represent like people inputs such as phosphorus. But what we started to do recently is to use like something else that other groups using is a virus that are present like that every human shed a lot. And it's like that virus called like a paper mild, pepper mild mottle virus. And so it's a virus that's been shown to be the most abundant virus found in human and fecal matter, And so that's been shown to be a good indicator actually of fecal matter. And so what we started to do like recently is to quantify in parallel that virus, which is also like an RNA type virus. So we can like go through the same process and use a different set of primer and probe sets and quantify that. So then we can normalize our results to that. So that's something I'm gonna try to do. We'll try to see if we can like, if the dynamics changing a lot or not using that. Another thing we've been doing that's been like a big part of our project is campus surveillance. So we started early September doing campus surveillance, and that when actually I did the first presentation, we didn't have much results. But what I can tell you is that it's been very helpful. So now we're monitoring like 10 different locations on the campus, which correspond to 2,200 students that are basically like monitored. And we use grab samples. So that means that here we cannot we don't have like an auto-sampler that does like a composite sample. It's like someone goes 1 or twice a day, take like a grab sample, and that's what we analyze. So it's like a little bit less representative than a composite sample. And so what we observe is like we are able to observe spikes in different housing. And so, for example, the first spike trigger a university response to go to that residence hall and test much more people. And so they were able to identify 6 new positive cases after that. So it looks like the way we've been using that, and it's really as a complementary tool for your university to basically trying to target area on campus that may be like a hotspot. And so that's exactly what happened mid-September. We started to see an increased concentration in viral titer on the Greek row. And that's something that the President Green communicated later on, that response when we that increase in concentration trigger a response for them to do a lot of testing on the Greek row and isolate some of the housing where they found a high rate of COVID-19. So that seems to be very helpful. And since then the concentration went a little bit down. And now what we're doing is we deployed an auto sampler since a week or two, and so we are gonna get for a little bit a more representative ID for our samples for different points. On that, so that's been very helpful and working very well. Yeah, I don't know if there's any question that's on that people have on our monitoring. I'll go now talk a little bit more about our pilot project plan. No? Okay. Okay, so the question now is a little bit what can we do with those concentrations? So that's been a big of a question that especially the city has. So the city is first and still do contracted this company called BioBot that is a spin-off company from the MIT that is starting very early on. They do what's called wastewater-based epidemiology. And early on, they're starting to set up those methodologies to quantify the virus in the wastewater. And they've been very in advance and helpful for that. And so what happened is that they starting to analyze contracted a lot of towns around all the USA and quantify the concentration of virus and came up with these case estimates. And so that's a little bit so they got a concentration of virus, they normalized that concentration of virus, and then they try to estimate the number of cases, and that's what's communicated to the cities. And that's really a question that we had a lot from the Moscow, which is first of all, what are those numbers mean? And what's the concentration? How can we use the concentrations to help to guide the local and public health authorities? So what we say is the trend, as you saw, right? We're literally analyzing the trend. So when we see a peak, in a changing concentration in the wastewater, it may indicate that there's more people getting sick. But in reality, what a lot of people are interested is to trying to know how many people are having are sick basically in the town. And that's what like this biobot company tried to do. And so early on, like they're starting to do those, reported the number of infected people by taking the total amount of virus per day that is arriving in the wastewater and dividing that number by the virus shed per infected person per day. So they came up with a number from like medical studies on an average like amount of virus shed per day. And that's how they estimated the count. And so that's like one of the first reports they sent to the city that were communicated later, like in the newspaper, is that they were like giving this reported COVID-19 case in Lalata County. On July 13, we had 30 cases, and the estimated was like 1,800 cases. So here got a little question for all of you students. So I'd like you to trying to tell me whether or not you think those numbers were at that time accurate or not. Okay. 5 of 12 responses, 6, oh, at least half people trying to answer, great. Okay, let's see what's the response of the people. What do you think? Do you think if it's good or not? So we got most of the people say the estimate number did not represent well the number of infected people in Moscow in July. Indeed, like if you look at that numbers, like I don't know, like I'm I think we're very skeptical to think that at that time really there was like 1,800 cases. And actually, like they came up now, they changed their model. They admit that that company that they were way more overestimated the numbers, and because first of all, like this average virus rate per infected person per day was not right. Like it's not right in the term that people apparently have been shown that the amount of virus that people shed in terms of quantity can be very like broad. Also, like as you see, not everyone is shedding the virus through the stools. There is much more, like it's much more complicated, and they were doing this simple calculation that was very wrong. Now they totally changed, like since September, their approach, and now they're using basically all the data they collected to do a model where they have like, this is all, like in the past, all the concentration we found, correlated that with the case reported, and do this correlation and estimate a number of cases. It's still like, it's way better, it's much lower, for example, for Moscow, more like accurate probably, but it's still like a little bit like a very simple way to do that. And so that's a big question so we're doing the monitoring from the city, and they're like, I guess it's like when you're trying to communicate like your results with like the public, like a concentration doesn't talk to someone. Like, what does that mean? Like, if you tell me there is this concentration of virus per liter, and except saying, well, the trends. And so that's kind of like a little bit like, again, there is a gap between like us scientists trying to like look at those data, and for like more the public trying to understand and what is the conclusion they have to take out of those data. And we're still having like those questions all the time. Is like, how many cases do you find? How many cases do you find? Like, we're not testing the cases, and that's what people want, is like a number of cases. So that's a little bit like the question that comes in like in the modeling part. So I'm not saying we're gonna try to do that, but it's a little bit trying to see how modeling can help to effectively guide local and public health authorities. And that sounds like a mission for IMCI, right? Like there is like doing some modeling. And so that's kind of like the idea behind that, is trying to put together like a pilot grant from the IMCI to try to see if we can use like wastewater testing to predict like COVID-19 outbreak in rural communities. Let me see. And and it's almost done. And it's a little like, this is for Holly that is here. Craig is not here. I've been like saying it's almost done since like 2 months now, and it's not almost done. I mean, like now it's almost done, but I don't know if it's like gonna be almost done. It's like kind of thing, you're like, oh, we're almost there. We almost have the proposal together. Oh yeah, oh no, there is much more. Like, so it's coming together. it's been way longer than promised and past due. So sorry for that. And so here a little bit like the what we want to try to do. So predict COVID-19 outbreak in rural community. Why a rural community? The main reason is that there are a population at risk that's especially like to develop like a severe outcome. Here's, for example, so that's very specific to the demographic of rural community, where like you have usually an older population that is shown on this map on the right. Like you got like a map of the USA with all the county and the proportion of the population over 65. And so rural area usually have like older population. Also it's been like the health overall, like, or the factor in health that make the outcome of COVID like worse are more prevalent among people in rural community. And another thing is like the rural community maybe are less likely to enforce maybe like for example, like wearing mask or social distancing. And that's being like a big political thing here in the USA. And there's just a survey here that asks the intention of wear a mask per county. And so they found that there was like basically like the intention significantly less likely as the level of rurality increase. So that's another like factor of risk. And we are here at University of Idaho in Idaho, so we're very well located to lead a study to trying to help like rural communities. So that's why we focus on that. And so here are the modeling parts, which is being thought and put together by Tyler. So I'm not really much a modeling expert, but the idea is to first, like our M1 is to leverage the wastewater virus concentration to develop a predictive epidemiological model for the COVID-19. And so working together, so he got like, came up with this model that is a compartmental ordinary differential equation that is very similar to like what's so-called like apparently a susceptible, exposed, infected recovery model, where you got a little diagram here that explain what is a model, where you got like a susceptible, someone susceptible that get infected. And Tyler, like you can stop me if I'm saying something wrong, because like I'm probably gonna say something wrong here. So you got infected, the person get infected by like someone that is either having symptoms or someone not like asymptomatic. Then you got like the pre-symptomatic stage where someone either become like symptomatic or stay asymptomatic. The person that is symptomatic either like can like there's to a certain rate can become dead, and then you got or recover. And here you got the asymptomatic people that recover this not recover is here, that become post symptomatic and then become recover. And so all those like pre-asymptomatic, asymptomatic, and symptomatic and post symptomatic like people all contribute to the concentration of the virus that is in the wastewater collected in the wastewater. And so the advantage of that type of epidemiological model is apparently that it can like be used, like the advantage it can like include like other variable in the model. And so the viral titer from wastewater can be included as a state variable. And we can also like play around and correct for some other variable to more accurately fit the wastewater data. For example, like the rate of shading through the stool, like the fact there's only have people like shedding the virus, our RNA extraction efficiency that we can estimate like with our internal control, our sampling frequency. So all of that can be included in the model. And so what we're planning to do is to train this model using our data set collecting from the University of Idaho, which is quite a unique data set because University of Idaho did like still like doing a huge effort to test a lot of people, and they end up to have these unbiased data sets where people volunteer and have to be tested regularly. So there's this data set on the university of all the people with where they live and whether or not they're symptomatic or asymptomatic. And in parallel, we've been like measuring for like a large fraction of people living on campus, the concentration of virus over time. So we think that using this kind of unique data set we have, it's kind of a little like golden mine we sit on, like we have this data set with the wastewater and the testing, we could actually produce a model that could be like very interesting to estimate kind of in forecast like COVID-19 outbreak. So that's our first aim. I don't know if anyone has any question on that or feedback. No? Okay. So our second aim is to trying to apply then this model to basically situation awareness, so predict number of people that will be eventually sick or infected, and forecast to see over time, can we predict like the trend of like the COVID-19 outbreak in a rural community. For that, we propose to test like 5 rural communities in Idaho that are listed here. They present the advantage that we can collect with the zip code the number like of cases that are reported. They are a rather low population, but high also that we can eventually detect like some cases. And they're also rather isolated. So the wastewater that we collect represent most likely the area. And so the idea is that we want to collect the wastewater twice a week for 3 months and use like the titer of viral titer we got from there, from the first point, to put that in our model and trying to estimate like the trend of the outbreak in a town, and then compare that over like over time with the real like data that are collected from the healthcare authorities. So there's a little bit like a gap here when we're gonna compare our results with the healthcare data. And so we're gonna have probably to work a little bit on that. And if you have any suggestion, that would be great. Is one of them is that the healthcare data, first of all, are not taking into account all the asymptomatic people. Well, the models that we're gonna build is gonna be able to do that. So the numbers obviously is gonna be different. So we may want to add some sort of a correction, correction factor from the clinical data to estimate what is the number of people really having the COVID. And so for that, maybe we could use like the statewide model that Ben has been working on, and probably with a lot of other people from the IMCI, that maybe also be used to estimate what is the amount of people in those towns really having the COVID. So then we can like are being infected. So then we can compare with wastewater data and see how accurate and precise is the model. On that, that's all. It's already time. Any question, feedback will be great, especially on the last 2 slides. No question. Okay. Okay, thank you very much. So I guess if there is no, do you have, or, yeah. Oh.
I have a question, Thibault. I'm sorry if I missed this, but is there something about this model that is rural specific other than maybe the age class distribution? So like, why couldn't this be applied to Boise or anywhere else?
No, so that's model actually like the way is being built, will be built, like could be used for anywhere else. It's true, and that's kind of like something that is interesting. One thing we are gonna have to be careful and really like read in the literature is by targeting the university, we're targeting a young age group, and so I looked already, and there's like not, it's very complicated, but I found some studies that show that there's not like the amount of virus shedded is not dependent of the age, but then also you read other studies where people that get severe outcome with the COVID shed much more virus than other people. So it's a little bit like we're gonna have to play around that, and probably have a correction factor if it's needed. And it's true, like actually it can be used probably it will be able to be used for another, like not only rural communities.
But I do think this could be really important in rural communities especially communities that haven't had outbreaks yet or don't have a current outbreak, because it's a way to monitor a community and have sort of a miner's canary that gives you an early warning. And I think that's one of the most promising things about this.
Yeah, the interesting thing is really like it can be very helpful for like rural communities to give, especially if people like maybe are far away for a testing center and maybe like don't want to be tested. I think like it can like also raise awareness, right? If you see like in your rural area like an increase in concentration, like the local like a local city can say, well, we observe an increase, so please be careful or respect the. Right now, it's a good time to like wear a mask or trying to social distance. That could be very helpful in this case.
Okay, I know this question is hard, but what is your current cost per sample?
It depends because we do per batch, and for example, for like the city where we do a lot of replicate. And we do 2 samples, like 2 dates in a batch. I think we charge, I think with including the time people, right? Something like $900 or $1,000.
$900 per sample?
No, for two samples, 2 dates.
Wow. Okay.
Yeah, it's mostly like people time, right? Like consumable, like are like $300-400 consumables, and then it's like people time. But for the campus, we are doing 10 samples, and we don't do as much replicate. We do like 1 replicate. We don't do like 3 replicate, and we can do much more at once. And so for 10 samples, we do $1,000, I think. So it's kind of like the same price. Like one is like $1,000, 10 samples, but less replicate. And the other one is for 2 days, 2 different dates, like $1,000, but much more replicate per sample. Okay.
Zainab had to go to a meeting with her like vice president of the university, but she wanted to know if you're using a digital PCR, I think, and which brand. I know this is a really specific question, but she asked me to ask.
Yeah. No, we don't. We're using a classical, I'll say like a qPCR, and digital PCR like is a very good tool for that actually. People show there's only one brand. It's only Biorad that sells that, so it's kind of easy. But we don't use that. Actually, like Holly, do you know where if that's gonna go through? Do you think or?
No idea yet.
No idea. Okay.
What is the benefit of digital PCR over PCR?
The benefit is that the absolute quantification are more precise. So that's kind of like the way you can see that the amount of virus, like the quantity you're measuring are more precise because you have less effect of inhibitory compounds. And that's something when you do environmental metagenomics overall, like, and you're using nucleic acid, like a DNA of RNA, when you extract those nucleic acid, it's never totally pure. You always end up with other compounds that interact with your enzymes and so inhibit the reactions. And so then like the amount of like by having not very well efficient like reactions, your absolute amount you quantify are biased. There is I don't know if Paul, you have any other to add, but there is like quite other advantage. Yeah.
It's also a great tool for doing expression studies. So we're trying to get one.
It's more accurate because you do a lot of PCR in a tiny volume, and because you're doing so much PCR, it's using like instead of quantifying, it's using like a presence absence by doing micro droplets, and so that's a little bit more precise. So basically, you can if you compare fold change between two samples, the significance is more accurate using like a digital qPCR, digital PCR, sorry, compared to qPCR, where when you have only 2, 3, 4 fold change, it's often non-significant with qPCR.
I will try to remember all of that to pass along, but thank you.
Okay. No, there's advantage. There's clearly advantage. The disadvantage, that's the thing, is like they sell that cleverly. Like it's not perfect. Is that the window of quantification is narrow, meaning that you need to have an idea about, like you need to test different dilutions, or in your sample you need to get an idea of where are your concentration you expect, because this window is very narrow compared to qPCR, where it's very large. Like you basically put your sample in and see how much you get. And so that one, like you can miss basically your sample if you don't know how much you can expect.